Frank Leone is going to be speaking about tobacco dependence and smoking cessation. He's the Pulmonary Allergy and Critical Care Division from the Perelman School of Medicine. I wasn't really sure why we invited somebody like Frank, because I've actually told all of my patients to stop smoking, and they all have, but the team told me that some of you are not having as much luck, so Frank is going to...
Thanks so much. Yeah, thanks so much for inviting me. Actually, I told all my patients to stop smoking, and they all looked at me with crossed eyes and they were talking about. And that's how I ended up getting involved with this. I can't believe it. It's 2017. I've been involved with tobacco dependence for 20 years. I know it doesn't look like I could be doing anything sophisticated for 20 years, right? But I've been at this for 20 years. And just the other day, I'm giving a talk, and the chairman of medicine listens to my talk, and she's going, And afterwards, the talk is over, people clap, and she comes up to me and she goes, I have a question. How do you stand all that frustration? I looked at her and said, wait, I don't get frustrated. How do you stand all that frustration? I said, this is medicine. This is what we deal with on a daily basis. We're dealing with the human condition. We're dealing with variability. We're dealing with people who sometimes do what we ask them to do, sometimes don't do what we ask them to do. And it occurs to me, she's totally frustrated because she's thinking about this problem the wrong way. Who here is frustrated by smoking? Raise your hand. Come on. All right, people. Yeah, there we go. If there's one truism in medicine, it's like I wish they would just stop smoking. If they stopped smoking, all these other problems would go away. If there was one thing that we could do for them, we would help them stop smoking and they'd get all better. Smoking is the single most preventable cause of preventable death, et cetera, and we're frustrated by it. So today, what I'm hoping we could do is have a little conversation about the nature of smoking, why it happens, reframe our interventions so that it's less frustratogenic. You like that word?
I like it very nice.
And then finally, actually come up with a couple of treatment strategies that are quick, simple, straightforward, easily integrated into the care of any patient, but in particular, patients for whom you're trying to manage diabetes. Now, how does this work? Oh, there it goes. I have no conflict of interest. I have no commercial relationships at all. I do get salary support from various government, either federal, state, or even city organizations to do research projects and that kind of stuff, but otherwise no commercial relationships. The objectives for today, we want to explore the tobacco addiction as root cause of chronic illness, including diabetes, by the way. We've often thought about diabetes as one problem, tobacco as another problem. They work together to cause a third problem. But really, it's all the same problem, and I'm going to try and prove that to you this morning. We want to talk about how to integrate tobacco treatment into chronic disease management. We want to review available pharmacotherapy for managing tobacco dependence. I am a physician. Oh, no, that's you. You're supposed to do that. Yeah, I'm not all three of those things. What do I do now? Just keep going? I'm going to keep going. There we go. Continued cigarette smoking undermines efforts at achieving adequate diabetes control through what mechanism? A, hypertension. B, vascular disease. C, oxidative stress and impaired beta cell function. D, inactivation of supplemental insulin. Are the clicker things working? All right, so what do you think the answer is? This is a tough one. It's a hard question. What kind of speaker ingraciously writes hard questions at 10:30 in the morning? It's not cool. Well, we're going to talk a little bit about oxidative stress and impaired beta cell function. So that's actually what we're talking about in terms of root cause. Like, why do all these things happen? Why does peripheral vascular disease happen? Why does cardiac disease happen? Why is it difficult increasingly over time to use these medications, insulin and otherwise, to try and control glycemia? Root cause has to do with oxidative stress and in particular in the pancreas with respect to diabetes, beta cell dysfunction. We'll talk a little bit about what that means in a minute. All right, tobacco dependence is a compulsive disorder characterized by willingness to change behavior, ambivalence in the face of behavior change, a deficit in motivation to quit, deficit in understanding regarding the health impact of continued smoking. What do you think the answer is? Another hard question at 10:30. Deficit, I got one for deficit in, which is it, motivation or understanding? Either one, right? People are like, both of them as far as I can see. This is actually where our eyes go. Turns out this is actually where our eyes go all the time when we're dealing with patients. And this is the frustratogenic part. What we see is what appears to be a deficit in understanding, motivation, skill. But what that deficit represents is actually a relative deficit compared to the motivation not to quit smoking. Tobacco dependence is not about not understanding that it's bad for you. Tobacco dependence is not about not loving your kids enough to care about whether you live or die. Tobacco dependence is about caring about how bad it is for you and still having something on the inside that says, don't change whatever you do. That's ambivalence, having two contradictory goals. They can be big goals, they can be really powerful goals, but they're split. It's like split personality. Two opposite directions. How am I doing so far? You guys hate this? You like totally hate it? So far, so good? If you hate it, will you let me know? Okay. Okay. Somebody, what's that? What's the answer? Ambivalence, yeah. Ambivalence. The answer is B. Ambivalence in the face of behavior change. Our eyes always go to the deficit of motivation, which is why. But once we recognize that a person can be desperate to stop smoking and still not be able to stop smoking, then all of a sudden, our willingness to provide help goes up, because we take this person who someplace inside of there wishes they could be different, and now we start to look for reasons or ways to change whatever it is that's holding them from making the changes they'd like to. Okay? Huh? What's that? Perfect question. If they're not ready to stop or they don't want to stop, that's it. They ain't going to stop. And so you know what? This is fascinating because this question came up to me for the very first time. Remember I told you I've been doing this since 1997? And yet I didn't actually deal with this question head on until 2000. I'm walking down the street, Walnut Street, in fact, and a pulmonary fellow standing next to me. She was about this tall at the time, and she's still this tall. What I mean is, at the time, I'm walking with a pulmonary fellow who's about this tall. Her name was Kate, and Kate's like, Frank, I get it, okay, I get it. So we got to go in there and we got to talk to them and we got to offer them help. I get it. But what if they don't want to quit smoking? What do we do? If they're not ready, what do we do? I said, Kate, their readiness is what we own. That's our problem. And so when somebody comes in and says, I'm not ready to quit smoking, that's not pre-contemplative. They've been thinking about it a long time. That is somebody who's screaming at us, there is something that is keeping me from affecting my goals. I'm not ready. I have something on the inside that's saying, no good, pull up, move, run away. That's what we own. That's our problem. And she's like, oh my God, I hope he gets through these. This is the first conference I've ever been to where you go to the refreshment table and there's Red Bull. So I had 2. No, I'm only kidding. I'm only kidding. All right, another question. This is a good one. Ready? This is a good question now. It's a good question. Varenicline, that's Chantix. Varenicline is too dangerous to use in diabetes patients, likely to cause emotional side effects, particularly in patients with pre-existing depression, effective even when patients lack interest in quitting, contraindicated in patients with a prior history of suicide attempt. What do you think? Which one? C? B. B, likely to cause emotional side effects. Most common answer. Turns out not to be true. Which one did you say? D. D. The second most common answer. Also turns out not to be true. Who else got a guess? C. 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 This is test-taking skills 101. I'm standing up here to talk to you about how to help people quit smoking. It's effective, even when people have no interest in quitting smoking. Damn. But you know what? This is the point where you do the mic drop. You say, if, in fact, a person's willingness, readiness, or lack thereof is, in fact, our problem, I can see how that might help somebody feel unable to really make a difference. But damn, if medications can actually forget about helping a person quit, but help a person feel ready to quit before they quit smoking. Now all of a sudden I have a lever of power. Ladies and gentlemen, this question is very important because the answer to this question implies that the problem that I'm dealing with is not the smoking. The problem that I'm dealing with is whatever's on the inside that keeps a person smoking. And if I can change that, regardless of whether they're smoking, the behavior will change over time without me doing anything. Here's the model. You decide to open up an obsessive-compulsive clinic. And you're going to take care of people who wash their hands obsessively, compulsively, right? You walk into that clinic and say, hey, you got to stop washing your hands. If you said that to somebody with OCD who washes their hands, what's the first thing that pops into their head? I can't stop washing my hands. This is a threat to me. What do I need to do in order to resolve this right now? I got to go wash my hands. What you don't run is a hand washing clinic. You see what I'm saying? What you run instead is an OCD clinic. So you deal with the emotional stuff, with the sort of what's going on up here that keeps that person washing their hands. You deal with all that first. You give your patient control. And then, and only then, does that human being use that control to change their behaviors. Does that make sense?
Yes.
Yes, it does. And so, yes. Excellent.
You still have to motivate that person to take that pill.
Well, so you do have to sort of be able to talk your way into getting the person to agree to take the pill. And so I'll say right now I'm going to give you we're going to jump ahead a couple of steps, but here's the idea. To be effective in this problem, stop talking about quitting smoking. I know I'm not supposed to say that. If you want to be effective dealing with this problem, stop talking about quitting smoking. Stipulate for that person. There's two people in there. One side says, I know you want to stop. I know that you're smart enough to already know that it's affecting your heart and your diabetes, etc. I know. But if I stipulate that, then there has to also be a second side of your head that says, oh, not today. Today's not a good day. Think about your own life. Maybe you have never smoked. And under most circumstances, somebody would say to you, well, if you've never smoked, you can't understand. No, that's not true. This phenomenon of ambivalence has everything to do with my belly, weight gain, has everything to do with whether or not I exercise, has everything to do with gambling, has everything to do with maladaptive relationships, has everything to do with all kinds of things, all kinds of social issues. They're not just about a deficit in motivation, they're about excess motivation not to change. And that's the side we're going to deal with. And so you stipulate, you say, I know there's two people in there arguing with each other. I want that argument to stop. Whatever you do, don't stop smoking. I always say that to them because they never expect the doctor to say that. I'm like, hey, don't stop smoking. Whatever you do, don't stop smoking. They get excited when I say that. See, they get so excited, they call me. They laugh. Oh, he said don't stop smoking. They make me write it down so that their family at home believes them. Okay? There we go. There's Mary. Actually, I don't really know this picture. I stole this picture off the internet. But I think of this woman right here as a sort of archetypal patient that you and I deal with. She comes in, she's got hypertension for many years. Maybe she's had a non-ST elevation MI in the past as a result. Her type 2 diabetes has been increasingly difficult to control. She has some emphysema. She's on oxygen. She can't get around anymore. You say to her, Mary, you need to lose weight. She looks at you and goes, I already only eat crackers and celery. Right? You say, Mary, you need to exercise. She's like, how am I supposed to carry this oxygen tank around? And you feel frustrated and unable to make a change in her life. And she says, what can I do to feel better? And you're like, Mary, I can smell the smoke on your clothes. Right? And so, yeah, right? You're like, you think about it twice. Do I bring it up? Do I say it again? Do I mention it one more time? She looks you square in the eye. She knows you're about to talk about smoking. You know she knows you know about smoking. And there's like this little instantaneous standoff. That's it. It's the elephant in the room. And suddenly, out of nowhere, you go, all right, so let's check your blood pressure one more time. Come on, tell me the truth. And that's what happens with Mary. And generally speaking, we think about the sort of most proximal impact of Mary's smoking is on her lungs. It's just here to remind me to talk a little bit about emphysema. But you know what? Emphysema is the sort of end stage clinical manifestation of years and years and years of ongoing inflammation in the lungs, tissue destruction in the lungs. And what we recognize now is that that ongoing inflammation and tissue destruction has as its root cause changes in the balance between pro-inflammatory signaling and sort of the brakes to the inflammation system. And that delicate balance is upset by a constant barrage of cigarette smoke. And so you don't have to memorize this, but this is really sort of in total, this notion of oxidative stress is inactivation of antiprotease enzymes, lipid peroxidation, depletion of antioxidant defenses, neutrophil sequestration, bringing all these white cells into the lung, and transcription of pro-inflammatory cytokines. These things are what oxidative stress are, and these things result in epithelial permeability, ongoing inflammation, cell injury, emphysema. But check this out. This is the path to heart disease. Oxidative stress, inactivation of antiprotease, depletion of antioxidant defenses, decreased nitric oxide production, increased oxygen-free radicals, endothelial cell injury, atherosclerosis, heart attack, death. All right, so you're like, okay, so lung disease and heart disease have a common progenitor path. Here's the key. Oxidative stress leads to beta cell dysfunction, endothelial cell injury in the pancreas. Both of those combine together to cause impaired glucose tolerance, difficulty managing diabetes, glycemia with medications. And so our job is not really to just check the A1C. Our job is to get at what keeps the A1C from being able to be controlled more easily. And so I would say that smoking turns out to be part, not adjunctive to, not parallel to, but core functional treatment of diabetes includes controlling the compulsion to smoke. Okay? Does that make sense? Does that make sense? Is this boring? Should I ramp it up a little bit? Do I need one more Red Bull? All right, this graph is really just meant to say that no longer should we be thinking about chronic illnesses as running in parallel. Chronic illnesses beget more chronic illnesses, and so there's a little bit of data along these lines. This is the sort of first graph that comes out, looked at a large population. Their primary focus was on COPD. But basically, this is a graph that says, what's the relationship between having COPD and the probability of having more than one chronic illness at the same time? And as the severity of COPD gets higher, I don't know why it's sort of backwards. This is the highest, most severe grade of COPD. The probability of having a second chronic illness goes up considerably. And if you're still smoking, the probability of a second chronic illness is about 40 to 50 times higher than it would be if you didn't have COPD and weren't smoking in the first place. So we're talking about chronic illness begetting chronic illness, and the core constituent, the root cause of a lot of those chronic illnesses having to do with the exposure to cigarette smoke. Specific to diabetes, this is one study that, that's cool. So there's this tuning technologies, thanks boss, appreciate that. So this is, brand new cohort of newly diagnosed diabetics. They all go someplace where they're going to get supreme control over their diabetes. People are going to work very hard to get their diabetes under control. And 1 year later, people are going to check to see whether or not they still have evidence of end organ damage, right? And so microalbuminuria is one of the outcomes. In people who continued smoking, the percent who had a decrease in microalbuminuria was 27%. But in people who were able to stop smoking during that year, the decrease in microalbuminuria was 77%. So that's the idea that control diabetes all you want. I mean, I'm not trying to say it that way. Work hard to control diabetes in order to protect the end organs. You're not helping 50% of the people if smoking is still part of the problem. Does that make sense? And then to give you an idea of the impact, say, on heart disease, right? We know that ACE inhibitors don't really do much to protect the coronary arteries. Statins seem to have a protective effect. I'm sorry, it's the other way around. ACE inhibitors seem to have a protective effect. Statins, they're not quite there. Smoking cessation improves the protective effect of medication. So when you put your patients on ACE inhibitors to try and protect their kidneys, you're giving them some impact, a 20% improvement. But if you help them stop smoking, you double their chances of protecting their kidneys. And this slide has to do with the relative impact on cardiac disease. So we're used to doing balloons. We're used to giving beta blockers. We're used to giving antiplatelet drugs. Most of the impact actually is equivalent to just helping somebody stop smoking. Imagine, I don't have to give you a balloon. I don't have to put you on Plavix. I don't have to give you beta blockers. I can get the same protective effect if I just help you stop smoking. And so why is this so difficult? Why is it frustratogenic? It has everything to do with the idea that dependence, the behavioral manifestations of dependence, are the cardinal signs of a disturbance in brain biology. So if you think about that for just a second, what I'm saying is when somebody says to you, I'm not ready to stop smoking, that's exactly the same kind of information as when you put your stethoscope on that person's chest and you hear wheeze. Wheeze might be the cardinal sign of their underlying emphysema or asthma. When they say to you, I'm not ready to stop smoking, that's the cardinal sign of addiction. There isn't one single addiction in the entire world that is manifest as an overwhelming willingness, certainty, to give up the substance of addiction. Correct? Can you think of one? I can't. And so it's that underlying brain biology that needs to be addressed before willingness will change. I got to address the underlying inflammation in the airway before wheeze is going to go away. I'm good with that. We got to change the underlying biology of the brain before that ambivalence goes away. Does that make sense? And so what is the biology? Here's the basic structure, basic scheme you got to kind of keep in mind. This is really about midbrain functions. These are not cognitive functions. These are not higher order cortical functions. This is what's going on in the midbrain. This is what's going on with feelings, with instincts, your gut. Okay? That's where this problem lives. All mammals on the planet share this basic set of structures or this basic sort of set of connections. In come sensory inputs through the eyes, ears, nose, fingertips. They pass through the spinal cord or the cranial nerves. They all pass through the midbrain, through a region of the midbrain referred to as the ventral tegmental area. And the VTA's job is to assess those signals for their survival relevance. Oh, there's a chocolate chip cookie out there. I want that. Or, oh, there's a barking dog out there. Woo, I don't want that. The VTA is the first stop on fight or flight because it figures out whether something is important to survival or not. The stuff that's not important to survival just passes through without a problem. Like Lucy on that conveyor belt. Most of the chocolates are getting by. Does everybody here know about that reference? Okay. Most of those chocolates are getting by. But on occasion, the VTA picks up a signal that is relevant to survival. And then it talks to other areas of the brain. Areas of the brain responsible for the generation of emotion. I need to be afraid of the barking dog. Areas of the brain responsible for motivation. I need to have the internal push to move away from the barking dog. Right? I can't mess this up. I can't look at a barking dog, feel safe, warm, comfortable, happy, get too close to the barking dog. Conversely, I can't look at chocolate chip cookies, food, warmth, security, safety, and go, oh my God, I'm so afraid to be warm and comfortable. That can't happen. So the VTA's got to be able to figure this out. And the VTA uses, the main neurotransmitter system the VTA uses is acetylcholine. Now that's important because you guys remember from your training that cholinergic receptors can either be fooled by muscarine, the muscarinic cholinergic receptors in the heart and the lungs, or nicotine. You remember? The nicotinic cholinergic receptors everywhere else in the central nervous system. And so the VTA is particularly sensitive to nicotine as an imposter neurotransmitter. And when nicotine gets in there, the VTA talks to the rest of the brain and says, good for survival, safe, warm, comfortable, love, happy, easy, certain. Survival, good. Okay? When you talk to the same patient and your voice and the meaning of your words hit the cerebral cortex where all the thinking, logical processing, the cognitive functions go on, and you say, gotta stop smoking, the VTA goes, oh, that's a threat. cognitively, Mary's saying, you're right, I got to stop smoking. The VTA instantly creates an emotional context against which Mary responds with, ugh. This is the source of the conflict that Mary cannot resolve. Are we together on this? This is the source of the conflict that Mary cannot resolve. Nicotine affects those ventral tegmental area receptors because those receptors are acutely responsive to changes in acetylcholine levels. And so when you deliver nicotine as the imposter neurotransmitter, you have to deliver it in a pattern that changes rapidly. And so here, these closed squares represent nicotine levels derived from a cigarette. The cigarette is delivering free-base nicotine. And so free-base nicotine is being absorbed through the lungs, coming back to the left ventricle, going straight up to the brain. Big bolus. Boom! The VTA sees a very rapid change in nicotine levels and has to respond to that. Compared to, for example, nicotine levels derived from the inhaler, which are really modest comparatively. Total nicotine amount is about the same. 30 minutes later, nicotine levels in the blood are the same. But it's really about concentration changes that make the big difference with the cigarette. And so your patient is not just sort of relying on the presence or absence of nicotine. If that were true, Mary would be able to stop smoking in response to a patch. Your patient's brain is also relying on the rate of change of nicotine. And the cigarette uniquely positioned to deliver nicotine very quickly because the nicotine in the cigarette comes out in the free base form. Crack. Did you know that?
I have a person who told me when they stopped smoking, they lost their best friend.
They lost their best friend. There's a total, when you stop smoking, you feel a sense of loss, the sense of depression, the sense of uneasiness, the sense of foreboding. That it's not like pain where you can just point to it and say, it hurts right here. It's just this overwhelming sense that things are wrong. It's not going right. And so in the face of that, is it any wonder that Mary then says to herself, you know what, today's not the right day to quit smoking. That's no wonder. That's what we're treating. We're trying to treat that sense of foreboding and that sense of loss, that sense of emptiness. If we can fill that bucket before they change their behavior, magic. Okay? You with me? Now, I've mentioned earlier that I believe this to be a chronic illness, not just because it takes a whole lifetime to help somebody stop smoking, but because the model for which we have to apply our thinking caps is more aligned with the chronic disease management model. This is not a cessation model. You don't go in, say the magic words, cut smoking out of their life. You're not smoking surgeons. What you are instead is you're going to control the compulsion over smoking. That controlled compulsion leads to behavior changes that are your target objectives. You're going to monitor control over the compulsion. And when control over compulsion loosens, you're going to re-exert control over compulsion. Just the same way you're managing diabetes. Okay? That's what makes it a chronic illness. And that is true because neurons exposed to nicotine change some elements of gene expression. And one of the genes that gets turned on produces this little protein unit that sits inside the cell. It's called delta phos-B. And delta phos-B is long-term. It sits around. It doesn't degrade very quickly. Years. And delta phos-B primes that cell to respond to nicotine. So it makes it more likely to respond to nicotine in the future. And so addiction and recovery from addiction is not about staying away from the substance for 7 days or 21 days and changing new habits and learning new ideas. Recovery from addiction is about staying away from the substance of addiction long enough for delta phos B to start to come back down towards normal levels. And that can sometimes take a while. That doesn't mean your patient needs to suffer for 3 years. Remember, your goal is to help them not suffer. But it does mean that we have to be vigilant more than just a couple of weeks. And when Mary's not smoked for 3 months and then comes back into the office and says, I had a cigarette, it's not a failure. It's an exacerbation. It's not a failure. It's an exacerbation. So your response is not, oh, Mary, I can't believe it. Okay, well, the patch didn't work. That's not your response. Not after today, it ain't. After today, your response is, all right, Mary, that makes sense. That makes total sense. Nope, don't worry. Hey, Mary, don't stop crying. It's all right. We're going to put the patch back on, all right, Mary? Okay? Smoking is a disorder of compulsion. Patients routinely not exactly ready, willing, or able. They are hesitant. That is the sine qua non. Patients want change but don't want change. They desperately want to quit smoking but don't want to quit smoking. That's a cool one. You agree? That's a good bullet right there. That is all ambivalence. And so we cannot look at our patients and say, come back when you're ready, because readiness is not either or in addiction. It's not that I am either ready or not ready. It is that I am both at the same time, simultaneously. In my heart, I desperately want to quit smoking, and, not or. Was that a little loud? Did I scream just a little loud, right? I know it was okay? All right. It's and, not or. I don't want to quit smoking. That's an important point. You agree? Our model is not cessation. We are not surgeons. We don't expunge smoking from their lives. This is how we've been thinking of it, and that's why we're so frustrated. But instead, like any other chronic illness, it has its exacerbations. It sort of naturally remits over the course of a lifetime. People experience their chronic illnesses in different ways. Our job is not to expunge smoking. Our job is to control smoking. Limit the amount of time in gray over an entire lifetime. You see that difference? That's the difference between a cessation model and a tobacco dependence treatment model. Okay? So how am I going to do this? Well, we've talked a little bit about some of these ideas, but any behavior change, whether we're talking about weight change, exercise, anything at all, is really the sort of sum total balance between the motivators and the disincentives. In general, in medicine, we've been taught to change this particular behavior by increasing the motivation. We tell people you're going to die if you don't stop smoking. And when they don't stop smoking, we say, well, you're disappointing your granddaughter. She hates you because you still smoke. Can't you see that? You're making her cry. And when that doesn't work, we say, well, you're going to get wrinkles. And at some point, we look for the magic thing to say. We look for the magic words to try and increase the motivation to a point where, I have to stop smoking. Sometimes it happens. That's true. But sometimes it does not. Because in the cases in which it does not, disincentives are on a completely different scale. They're happening in a different part of the brain. They're big. They're substantive. It's about survival. And they are immutable. They are immune to your pleading. And so our job is to find ways to decrease the disincentives at the same time as we're managing motivation. But we must decrease disincentives to moving forward. Now, there are behavioral ways to do this, and at some point, maybe next year, we can come back and talk specifically about the behavioral ways to get this done. But first and foremost, before you even think about behavioral techniques from a sort of structural point of view, recognize that our frame from which we've been approaching this problem has been shooting our own feet for years. Okay? And if all you do is change your perspective from looking at motivation, move your eyes over to disincentives, and work to minimize the impact of those, That's really all the behavioral strategies you kind of need, honestly. One of the biggest ways of minimizing disincentive beyond the behavioral stuff is actually through pharmacology. So I want to just talk a little about some of the pharmacotherapies, and then we can answer some questions. This is a cartoon that's meant to remind us of the pharmacokinetics of different nicotine delivery devices. So in red is the cigarette, big peaks, okay, quick, crack. In green is the 24-hour transdermal nicotine delivery device. Just like you expect, it's going to be low, slow, and sustained. Makes sense. In the middle are these acute delivery devices like gum, lozenge, inhaler that give you a little bit of a bump, but not nearly the same as a cigarette, but more than a patch. Okay? And so by recognizing that difference in pharmacokinetics, we can actually start to put together a strategy of what I like to think of as controllers and relievers to manage the compulsion to smoke. The first control you should be aware of or familiar with is the patch. Generally speaking, people are afraid to use the patch. 9 out of 10 prescriptions for patch underdose. So don't be afraid to give the appropriate dose. In the old days, you were taught, I am supposed to take the number of cigarettes they smoke in a day, multiply by how many milligrams of nicotine are in each cigarette, roughly approximate 1 pack a day, 21 milligrams patch. The problem is absorption through 1.5 square centimeters on the skin is very different. And so even people who are smoking a couple of cigarettes a day are being exposed to large amounts of nicotine in the lungs. So use the big patch, even for like 5 cigarettes a day. Think about their smoking behaviors, how aggressively they smoke, not the number of cigarettes. Start high, gain control, and then back off. The other thing about these medications is they had been previously labeled as 8 to 10 weeks, then stop. We know that controller medications, you pick the duration based on patient's response. So clearly, there are lots of patients who need more than 10 weeks. That's fine. Use it. 3, 6 months, 8 months, 10 months, a year. No problem. Use it. Gain control. Back off when you get the subjective sense that control has been, you're under control. You don't want to give the patient more medicine than they need, but you definitely don't want to give them less than they need. Does that make sense? Evidence in favor of using the patch. These are from the guidelines. The strength of the evidence is A. Using a patch essentially doubles the likelihood that Mary will put the cigarettes down. Gum, 2 and 4 milligram doses, almost inevitably, we recommend the 2 milligram dose. Medicine recommends the 2 milligram dose. Almost invariably, everybody needs the 4 milligram dose. So use the 4. Don't use it like gum. Tell Mary it's not gum. It looks like gum, but it ain't gum. Think of it more like chew tobacco. Chew it just to get it soft, then plaster it up against the inside of the cheek and gum. The bigger the contact patch, the more stable the contact, the better the absorption. Nicotine levels do this. The brain says, thank you. When you use the patch all by itself, when you use the gum all by itself, it improves your likelihood of cessation by about 50%. So keep that in mind. So if you use the gum by itself, it improves the likelihood of cessation by about 50%. The other acute nicotine replacement product that I like to use, which is available by prescription, is this nicotine inhaler. Empty plastic tube, put this little cartridge on the inside, puff on it all you want. There's posterior pharyngeal absorption of the nicotine. It's not free-base nicotine, so they don't get the hit, but they can use as much or as little nicotine as often or as infrequently as they like. So it's very titratable. Okay? Evidence in favor of the inhaler. The inhaler doubles the likelihood of abstinence. Now, when you use them together, remember, I get double the likelihood from the patch. I get double the likelihood from the inhaler. I get a 50% likelihood increase from the gum. But when I put gum or inhaler on top of the patch, compared to doubling, I almost quadruple again the likelihood of cessation. And so if you remember nothing else from today, your ability to manage the compulsion to smoke using nicotine replacement products is actually on par or even better than your ability to manage hypertension using the common drugs that we use. You double the likelihood using the patch. You quadruple it again if you add the inhaler on top of the patch. Okay? Bupropion started life as an antidepressant, or some of us are familiar with it from that point of view. Generally speaking, it works in the motivation parts of the brain to sort of decrease that impulsivity of compulsion. And so you use 150 milligrams twice a day. The product insert says use it 7 to 10 days before quitting, but usually it takes a month or two even before total effectiveness goes up. So start it as a good controller. A month from now, they come back, you bring them back for another visit, 6 weeks, something like that. Add the inhaler, something along those lines as a reliever, and boom, you're really increasing the likelihood of cessation. Bupropion alone, double probability of quitting. Bupropion plus some nicotine, some form of nicotine, double again. So quadruple or 5 times the likelihood of cessation. Notice that's pretty good. That's pretty good odds ratio. You agree? Varenicline. So the key about varenicline is patients have been taught to think that they need to use it for a week and then stop smoking. And so what happens to almost everybody is 1 week into it, they still want to smoke, so they said, this stuff doesn't work, and they stopped using the varenicline. But that's not how to use varenicline. Even when somebody doesn't want to stop smoking, this is a cohort of about 1,500 people who did not want to quit. 1,500 people. There's no shortage of people who don't want to quit smoking. There's 1,500 people who were not ready to quit smoking. They got either put on placebo or got put on varenicline and then watched over time. And 16 to 20 weeks later, they're still accumulating people who are quitting on the medication. 4 months later. So varenicline sort of works cumulatively over time, even when people are not ready to quit smoking. All right. A couple of useful web resources. This should be in your slide set. This is our website up here. And then this one we do different training programs, so if you're interested in learning more. And then this one's the American College of Chest Physicians, has a nice toolkit that can be integrated into practice, help with the flow. Points to remember. Smoking is the behavioral manifestation of a disturbance in brain biology that is induced by exposure to nicotine. The cardinal symptom of the pathology is compulsion to smoke, which is always, always, always manifest as reluctance to stop. Smoking cessation is cost effective and has a significant impact on morbidity of whatever chronic illness you're treating, particularly diabetes, in terms of downstream end organ damage. If we always do what we've always done, we'll always get what we've always gotten. I always end my slide talks with this slide, which I think is sort of cute. But anyway, that's my number. If you need me, give me a call. Questions? Nothing? I think they hate me. Raise your hand if you hate me. Do you hate me? Raise your hand. Anything? Do you think it's feasible? Have I said anything at all to change your approach to patients with tobacco dependence? Anything? One little thing? Can you identify one thing that you'll do differently tomorrow than you were doing yesterday as a result of this lecture? What would that be? Sorry? Sorry? Yeah, you like that one. Don't stop smoking. Oh my God, they fall over when you say that. What else? I'm sorry? Be more generous with nicotine replacement. Don't underdose. Don't be afraid of it. There's no morbidity associated with nicotine replacement. Use it in combination. duration of time, right? So this is not 6 weeks, and if it hasn't worked, it's a failure. This is, I have not gained control yet, so I need to get creative with how I'm going to proceed with this. This is a chronic disease time frame, not a surgical time frame. Yeah?
How about patients that come to you and say they have vivid dreams?
Yes.
Stuff that they don't want.
Yes. I say, my God, tell me about your dreams. I want to know. And sometimes they go, well, I can't tell you. And that's when you both laugh and you say, you know what you need to do? Take the patch off before you go to bed. Or if it's vivid dreams because of one of the pills, you say, what time are you taking the pill? Bedtime? Okay, don't do that. Take it at dinner time. But what you don't say is, okay, it didn't work. You say, we got to be creative. Just like every other medication, if there's a side effect that is not obviously not dangerous but uncomfortable, we don't want to accept that side effect. We want to manage that side effect.
How about drug interaction with Chantix and SSRIs?
There is no drug interaction between Chantix. The only thing to worry about with Chantix is when renal function drops below, if the GFR is below 30, then it requires a dose adjustment. But other than that, there's no drug interaction. So even SSRIs or other antidepressants. Now, bupropion, you have to be sure they're not on another bupropion-containing product. But other than that, there's also no contraindication. All right, folks, I had a great time. Thanks very much. I appreciate it. Thank you.